AntiPhosphoLipid Syndrome, APS, a clinician's overview. Opening. Imagine a young woman, just 28 years old, who has already suffered 2 miscarriages. Pause 2 sec. Later, she develops sudden leg swelling and pain, a blood clot. Testing reveals antiphospholipid syndrome, or APS. APS is an autoimmune condition where the body produces antibodies that make blood more likely to clot. These clots can form in veins, causing deep vein thrombosis or pulmonary embolism, or in arteries, leading to stroke or heart attack. In pregnancy, APS can cause miscarriages, preeclampsia, and poor fetal growth. The most feared form is catastrophic APS, where clots form all over the body within days, leading to multi-organ failure. Though rare, it is life-threatening. Then definition and diagnostic framework, 04fin. Let's understand this step by step. APS is defined by 2 things: clinical evidence of thrombosis or pregnancy morbidity, and persistent antiphospholipid antibodies detected on blood tests. According to the revised Sydney criteria, we need at least 1 clinical and 1 laboratory criterion confirmed on 2 occasions, 12 weeks apart. The 3 key tests are 1. Lupus anticoagulant, 2. Anticardiolipin antibodies, IgG or IgM, and 3. Anti-B2 glycoprotein 1 antibodies, IgG or IgM. Transient positivity can happen after infections, so persistence is the key. Pathophysiology. Now, why does this cause clotting? These antibodies don't attack phospholipids directly. They bind to proteins, mainly beta-2 glycoprotein 1, on endothelial cells, platelets, and trophoblasts. That binding activates the endothelium, increases tissue factor, complement, and platelet aggregation, while impairing natural anticoagulant systems. In pregnancy, these antibodies disturb trophoblast development and placental blood flow, explaining the miscarriages and growth restriction. So, thrombosis in vessels and failure of placental function, 2 sides of the same mechanism. Clinical spectrum. Clinically, APS presents in 3 broad patterns. 1. Venous thrombosis, such as DVT or pulmonary embolism. 2. Arterial thrombosis, for example, stroke or myocardial infarction in a young patient. 3. Obstetric APS, recurrent miscarriages, fetal death after 10 weeks, or severe preeclampsia. And at the extreme, catastrophic APS, or CAPS, where widespread clotting causes multi-organ failure within days. Triggers for CAPS include infection, surgery, or sudden discontinuation of anticoagulation. Diagnosis, step-by-step approach. Here's how we approach it clinically. Step 1. Suspect APS in young patients with unexplained clots, recurrent miscarriages, stroke, or when autoimmune disease like lupus coexists. Step 2. Order all 3 antibody tests: lupus anticoagulant, anticardiolipin, and anti-beta-2 glycoprotein 1. Repeat after 12 weeks to confirm persistence. Step 3. Interpret the pattern. A single low-titer antibody may be low risk, but double or triple positivity, especially with lupus anticoagulant, means high thrombotic risk. That pattern guides both prognosis and management intensity. Returning to our earlier example, the 28-year-old with 2 miscarriages and a DVT. Persistent positivity for lupus anticoagulant confirms APS. Now the miscarriages, the clot, and the antibody pattern all fit into one unifying diagnosis. Treatment, 530-thin. Let's look at management. 1. Acute thrombosis. Treat like any venous thromboembolism. Start heparin, either low molecular weight or unfractionated, then switch to warfarin for long-term therapy. The usual INR target is 2 to 3, but for arterial or recurrent events, higher targets may be used. Most patients require lifelong anticoagulation because the recurrence risk remains high. 2. DOACs warning. Direct oral anticoagulants, or DOACs like rivaroxaban, are not recommended for high-risk APS, especially triple-positive profiles, because they've shown more arterial events in trials. Warfarin remains the preferred choice. 3. Pregnancy and obstetric APS. In pregnancy, the goal is prevention. Low-dose aspirin combined with low molecular weight heparin significantly improves live birth rates. If there's a history of thrombosis, therapeutic doses are used. Otherwise, prophylactic doses are enough. Continue anticoagulation 6 to 12 weeks postpartum because clotting risk stays high after delivery. Example, pregnancy case, 7s. Imagine a woman who's had 3 early miscarriages. She starts low-dose aspirin and LMWH early in pregnancy. This time, she delivers a healthy baby. That's the power of recognizing and treating obstetric APS appropriately. Catastrophic APS. Now, a brief word on catastrophic APS. This is a medical emergency. Treatment is threefold. 1. Full anticoagulation. 2. High-dose corticosteroids. And 3. Plasma exchange or IV immunoglobulin to clear antibodies. If lupus coexists, add cyclophosphamide. Without rapid action, mortality is high, so early recognition saves lives. Long-term management and prevention. Beyond treating clots, we must prevent them. Avoid estrogen-containing contraceptives. They raise clot risk. Encourage smoking cessation and control of blood pressure and cholesterol. For asymptomatic antibody carriers with high-risk profiles, low-dose aspirin can be considered for primary prevention. Monitor INR carefully, since lupus anticoagulant can interfere with some lab reagents. Always use consistent testing methods. A multidisciplinary approach with hematology, rheumatology, and obstetrics gives the best outcomes. Summary and take-home points. To summarize, APS is an autoimmune clotting disorder defined by clinical thrombosis or pregnancy morbidity and persistent antiphospholipid antibodies. Pathophysiology, endothelial, and platelet activation leads to thrombosis. Diagnosis, based on the Sydney criteria with repeat antibody testing at 12 weeks. Treatment, warfarin-based anticoagulation for thrombosis, aspirin plus heparin for pregnancy. Avoid DOACs in triple-positive or arterial APS. Recognize catastrophic APS early. It can be fatal without prompt combined therapy. Understanding APS links together what may seem like separate clinical problems, a stroke in a young woman, a deep vein thrombosis, or recurrent pregnancy loss, into one unified, treatable diagnosis. Recognizing that pattern can truly change outcomes for our patients.